Welcome. I'm Penny. I'm the director of the Q Initiative, and it's my pleasure to chair this session exploring how quality improvement methods have been used during the rapidly unfolding crisis situation we find ourselves in. I'm joined by two leading thinkers and practitioners in improvement. I'm going to hand over in a minute to John Fitzsimons, a consultant paediatrician in the Children's University Hospital in Dublin and clinical director with the Health Service Executive's National Quality Improvement Team. And we'll then have a second short presentation from Amah, Shar, a forensic psychiatrist and Chief Quality Officer at East London Foundation Trust. I'm then armed with some great questions informed by Q's annual Insight Survey, which this year focused on the role of improvement during COVID. I'm really looking forward to getting your thoughts on the particular strengths of improvement for this sort of context, but also what we can learn for this once we're out of the immediate crisis mode. By the end of this session, you can expect to know more about how others have been using quality improvement approaches and have the chance to reflect on what this means for how we all practice improvement. So, John, over to you to kick us off.
Thanks, Penny, and it's a real pleasure to be here with you and Amar this afternoon. Thank you very much. I'm going to talk a little bit about using QI in a crisis, and I'm going to make reference to a paper that I wrote back in March, and it got published in June. And the reason I wrote this was I thought it was really important that we talked about how useful quality improvement and patient safety as ideas and practices could be during the crisis that was unfolding at the time. The basis then really of the article was about this idea of rapid learning cycles and how do we learn. And I love this quote from Samuel Beckett: "Ever tried, ever failed, no matter. Try again, fail better." And I think a lot of the ideas of design are based on the ideas here of trying, but trying in a safe way, trying small, trying kind of, with one test, one day. And these rapid learning cycles, they can certainly be too big, but they can almost never be too small. And one by one, we can learn. And I think in a crisis situation, this is really important because, again, we want to do this without getting in people's way. And so having small tests, small measurements, really kind of taking the minimum that we can to learn and to progress things. One of the things that a crisis really emphasizes is how, as improvers, we need not to be in the way, and that we need to be very respectful of people doing work in the front line, and that sometimes they won't necessarily appreciate that we're trying to improve things. So how can we do that in a respectful way that really puts as little or no burden on them as possible? And I think there are lots of ways that we can do that. Now, I think in terms of using measurement, sometimes we get concerned about needing objective numerical measures, but that doesn't always have to be the case. I think I would equate with measurement, observing or listening, and certainly at the early stages of working out an idea. Is this something that's going to work if I change the way that we use our personal protective equipment here, if I change the way that we administer medication because of the new demands of COVID, I may not need to have a lot of process measures of measures of time or medication adverse events. Simply observing and listening, and it's this idea of a degree of belief, and I think this is a really important idea that kind of comes into its own almost in a crisis situation. This is a nice little graphic of this idea from Gareth Parry from an article a few years ago, but it shows here in the early phase, in the innovation phase, as he calls it, we can have a low degree of belief. So it can be an opinion or somebody past experience of something that can inform our degree of belief. As we move along, then we might need something a little bit more rigorous. And then ultimately, we might want something that really can stand up to a greater scrutiny of evidence. And you can see here that the number, again, of these measures, whether they're simple numerical measures or observations or things that we've learned from talking to people is greater, because we need that to build up the degree of belief, and then we can get away with less as they become a little bit more rigorous. So they were the main ideas that I wanted to bring forward, and I think, like I said, they are, I believe, of great value, because this is so useful in everything we do, because all of the difficulties in the pandemic has called for redesign of things. We cannot do things the same way as we used to. So we need to redesign lots and lots of elements of our care systems. But it's also a really good way, I think, to learn about the fundamentals of quality improvement. One of my stars, I think, of the pandemic so far has been Dr. Mike Ryan from the WHO. And I just love this quote early on. And I also think it's something that Edwards Deming himself could have said, that perfection is the enemy of the good when it comes to emergency management. Everyone is afraid of the consequence of error, but the greatest error is not to move. Error is paralyzed by the fear of failure. And that's what Deming talked about, driving out failure. And I think driving out fear. This is so important to drive out the fear, for people to feel that they can try, test, and safely create new knowledge. So they're my thoughts on how it can be useful, and I look forward to having our discussion.
Thanks, John. That's a really fantastic overview of some important principles. We're going to move straight on to Amah now, who'll be sharing examples of how key improvement methods have been used in practice. So, Amah, over to you.
Thank you very much, Penny. I'd like to provide some examples to demonstrate how John's theory about how improvement science and patient safety science could be useful during the pandemic is actually borne true. And what we've been able to find from across the healthcare system is examples of how people have been applying quality improvement during COVID. And they've been in a number of different areas. First of all, around standardizing and improving processes. Secondly, around using tools such as the driver diagram to bring together a shared theory of change. Thirdly, around measurement, which John just described. Fourth, around the use of rapid cycles of learning and testing. And then really less frequently, but I will come to this, is about the use of rigorous and robust quality improvement projects for complex problem solving. And then finally, I'm going to come back to how services are starting to redesign for the future using quality improvement techniques. So I just want to walk you through a few examples of what we've been able to see across the country in the application of quality improvement, and then bring that together with some reflections about what that might mean for the future of improvement. Examples of processes that have been improved through coronavirus are many. This is just one example of a process that we at East London Foundation Trust standardized. It was quite a chaotic process, first of all, but we brought some improvement tools to help us standardize the process. And we ran a number of plan, do, study, act cycles to test this and scale it within one working day, automating and digitizing it at the same time. So that's an example of really bringing the best of improvement to bring some stability to a complex process. We've also seen a number of examples of the use of a tool such as the driver diagram on screen here, which has been used to bring together a range of people to create a shared theory about how they will achieve a goal. And we've got examples on the screen here from ELF, but also from a collaborative run across the north of England for musculoskeletal services, and also how Einstein hospitals in Brazil have brought a driver diagram together to help them think about how they can reduce harm to employees during the pandemic. So good examples being used of driver diagrams to formulate strategy, which can be really helpful at times of complexity to bring a simple visual image to help provide some direction and clarity around the things that we need to prioritize. Measurement, I think, has been a challenge during coronavirus because we need to balance the needs of rigorous measurement with what's also not going to create demand on the system. But here's an example of how Einstein in hospital have used data over time in a really robust way to demonstrate improvement on something that really matters during the pandemic, like the number of employees with a first positive test. Here's an example we've tried to use at East London Foundation Trust to bring data together into a single page dashboard so that our management team can have real-time information to inform the decisions that we're making on a balanced scorecard of outcome, process, and balancing measures. And I wanted to bring up the topic of quality improvement projects because lots of people have said anecdotally that there's no time to really use quality improvement in the rigorous, robust way that we sometimes used to use it. And there are some examples of being able to do this. So here's an example from my organization where we've taken a complex topic like the experience of people on our wards who are awaiting test results. And using that negative experience to help us really discover new ways of working through a proper process of quality improvement, starting with understanding the issue from multiple perspectives, building a strategy, and then using data and tests of change to improve the system, using all of exactly the same approach that we would for a normal quality improvement project. And finally, what we're starting to see now is services using quality improvement to learn, make sense of all the change that's taken place, and then think about their design going forward. So now we're moving from quality improvement to probably quality planning and using principles such as the Triple Aim framework to help inform service redesign for the future. And we've certainly tried to encourage all of our services and our service users to together help make sense of change, help understand impact of change in a structured way, and then think about co-designing what the future service should look like around outcomes that really matter for our local citizens. So with that set of illustrations of how quality improvement has been utilized across the system, some reflections on that for me. Well, first of all, I think people have broadly welcomed the opportunity and the autonomy to make change happen and to adapt as they learn. I think that's been a really welcome feature over the last 6 months. They've also, I think, appreciated leadership approaches that have supported local decision-making rather than command and control. We've, I think, seen the benefit of this singular purpose that we've all been working towards, which I think shows the power of what Deming described as constancy of purpose. Our learning from this really ought to be that as leaders, our role really is to create the conditions within which people can discover solutions to our most complex issues, and also to bring line of sight from mission through to what teams are working on at point of care. And I think that's been shown to be really powerful over the last 6 months. However, what I would add is that having autonomy to make change, whilst liberating, isn't enough to say that we're really adopting quality improvement. We need to also use tools to help us with daily problem solving in a structured way, and also use quality improvement in a project method to solve the more complex problems systematically. And my theory is that those organizations that have invested in building a culture of systematic experimentation and discovery, who've trained up their workforce with the skills and tools for this, and coached their leaders to adopt the requisite behaviors to support this, are much more likely to be able to deploy these at times of crisis. But I think one key learning for us also has to be the need to simplify. People have talked about the liberating experience of not having to worry about language and methods and just being able to make change happen. And I think we can learn from that we sometimes make improvement far too difficult. We need to remove the jargon. We need to remove the technical language. We need to think differently about all the methods we sometimes throw at people, because at their roots, they all have the same principles, and we need to simplify and make improvement much more accessible for the future.
Thank you, Amah. I'm sure I'm not alone in feeling really inspired by what you've shared. And we've got an opportunity now to develop some of those themes, drawing on some of the findings from Q's Insight Survey. We captured data from over 200 Q members on the way that they have been using improvement mindsets, tools and approaches during COVID. So I'm going to hone in on some of the particular more difficult debates and challenges that we saw coming through in the results. So I'm really interested in what you were saying about kind of methodological flexibility, which also comes through in the survey. Insight from Q shows that a wide range of improvement tools, methods and approaches are being used for a whole range of purposes by members, sometimes with high fidelity to the specific method, but often much more flexibly. And indeed, many people reported finding it kind of freeing to focus on the essentials, and that this helped to enable rapid change and wide engagement that was particularly important in the context of COVID. But we also heard concern that this lighter touch improvement might become the standard longer term, losing rigour in important ways, I think as you touched on in your presentations. What lessons do you think we should be learning during COVID about the relative value of applying improvement mindsets and principles flexibly, versus using the methods as formally defined in a rigorous way?
So my sense would be, Penny, that we don't have a choice in front of us. We have to do both. To really embed a culture of continuous improvement, you need to be both tackling the big, complex, wicked problems through systematic, structured projects, and you need to be using tools in your daily problem solving and daily work. And what I think we've witnessed is lots of application of tools and lots of change happening rapidly. Change not necessarily representing quality improvement unless we can be sure that things are actually improving through some sort of measurement. But my sense is we need to hold on to the principles of really good improvement. That is, there needs to be some rigor. There's a science. We need to utilize the scientific basis for the work. And we need some skill, and we need to practice it. And we need to practice it both in terms of daily problem solving and the more complex problem solving, which actually we need now more than ever, because we have really difficult challenges to solve and we don't know the answers to them, which are absolutely perfect for the rigorous, robust quality improvement project approach.
How do you know when to guide people to use a more rigorous approach or to do something more quickly?
The way I help people try to differentiate that is very simply around the difference between technical problems and complex problems, and trying to help people recognize when is there a problem to which we actually don't fully even understand the problem, but we have theories about it, we have ideas, but we don't know what's going to work, we don't have the skills maybe necessary to solve them yet, versus technical problems where we've seen them solve them before and we have known solutions. And bringing that to life with some real life examples can help people. But I think people recognize where there's some complexity or wicked problems in the system that we're going to need to discover our way through.
Thank you. John?
Yeah, I would be very much a principalist, I think, on this, question. I think that the most important thing is to have the principles behind you. And I think if we know what it is we want to achieve, then I think the rigor will come. There's a risk sometimes, and I think many people will tell you how they came to quality improvement through learning about a tool without maybe understanding the reasons and the principles behind it. Whereas I think the tools are much easier, much better applied when there's a deeper appreciation of the principles.
Thank you. I guess that comes with time, both individually and in terms of the organisation's understanding. And let's look to the future now. So COVID has brought all sorts of immediate operational crises to manage. But as we look ahead, there are also longer term, more complex crises upon us. So the backlog of patients waiting and unmet need, widening inequalities, and workforce and financial sustainability challenges. I'm interested in how far you think the methods that you've spoken about can help to address these kind of bigger crises, and what else or different you think will be needed.
Yeah, I've got two thoughts really to that question. One is, look, what other option do we have? These are really complex, wicked problems to which I don't know that anyone has the answer. So surely the approach, I'm sold on this clearly, but the approach has to be to build a theory, involve people widely, get out to the point where this issue is closest to being felt, and let's experiment and discover and measure as we go. Now, if anybody has a better approach than that, I'd love to hear it. I'm not convinced, though, that people truly believe that at all levels of the system. So certainly when we're thinking about workforce and finance, the approach to planning is pretty old school right now. Whereas actually in some of our complex issues, like how do we run dementia assessment services? How do we manage backlogs and waits? Actually, we are applying quality improvement in a really rigorous, robust way. And that's just because we have belief that that will help us find new solutions that we haven't thought of before. I think the other thing I would add to this is we have an opportunity now to improve the way we improve. Just like we're asking every service to think about how it needs to reshape and redefine itself for the future, we also need to think, how are we going to improve the way we improve? And that means getting rid of bureaucracy and jargon and things that are in the way of people improving, make it more accessible, simple, and put improvement in the hands of everyone. And I think we really have an opportunity to demonstrate how to do improvement really well. And that would be the challenge I set to everyone.
Thank you. John?
Yeah, I think there's a tremendous opportunity here. There's always been tremendous opportunity. I suppose COVID again has been a great revealer of deficiencies in how maybe we've organized things, and it will, I think, in time be a great accelerator of certain interventions such as telehealth or things that were maybe coming along but are going to come along much faster now. I think it really does ask the question, about transforming, I think, what we do. It's not about just putting the old system back together. I share Amah's optimism here in the potential of quality improvement thinking and redesign to have a tremendous effect. I think in terms of leadership, though, that needs to be really kept in balance, I think, because people need to be reassured that we're not going to do everything through quality improvement without involving them, without hearing their ideas, without bringing them along. There will, of course, be places that we need more. We need more investment or different equipment or different resources to do things. But I think the potential of quality improvement is tremendous. But it takes time, to build that knowledge, to build that capacity, to shift power. I think is a key thing. The autonomy that we've seen in the crisis, I think, is just a little inkling of that change of power, and there is tremendous potential that we've seen there. I think it'll be much harder maybe to hold that and for that to become the new way of working. But I think all of the experience from I think global leaders here in quality improvement, be it in industry or in healthcare, is autonomy and getting the ideas of people to test them, experiment with them, and bring them forward. That's where change happens, and that's where transformation happens.
So thank you. We'll need to wrap up the conversation here, but I hope what you've heard will spark further thinking and debate. Thank you to John and to Amah. The work that you described is being published and will be shared alongside this recording. If you'd like to know more about the Q Insight Survey results, there's an on-demand session which goes into more depth on the findings and what they might mean. And please do share your thoughts through Q in response to what you've heard. We really need to make sure we learn all we can as we carry these methods through into the next phase of the pandemic. Thank you.